Now we have another interesting topic, inpatient management of diabetes, for which to speak on this, one of the toughest topic I would say, we have Dr. Joel Franklin from Nagarkoli. Is a practicing clinical endocrinologist at Nagarkoli and has published papers, publications. I invite Joel Franklin to tell his lecture.
Thank you. Before I start, I would like to thank Kumaravel sir for giving me this wonderful opportunity. So this will be a short discussion on inpatient glucose management. So around 25% of non-critically ill hospitalized patients have diabetes, and among them 15 to 25% have hyperglycemia. And it is a well-known fact that diabetes and hyperglycemia leads to prolonged hospital stay, increased incidence of complications, and disability after hospital discharge. So what is this hyperglycemia in hospital? So definition is the blood glucose is more than 140 mg per deciliter, and definitely you have to go ahead and do a HbA1c. And if there is persistent hyperglycemia more than 180, then you start the patient on insulin. So how to manage an in-hospital setting? So insulin is the ideally recommended therapy, and why it is not generally recommended, although I will come to it later. So in critically ill patients, it's better IV insulin infusion. For non-critically ill patients, it is better to go with subcutaneous insulin. So what are the glycemic targets for critically ill patients? The starting threshold, as I told earlier, it is more than 180. So once IV insulin is started, the glucose level should be maintained between 140 to 180. Only in selected patients, the lower glucose target can be set in around 110 to 140. And generally, targets less than 110 or more than 180 are not recommended. So which regimen? It all depends on the eating pattern and severity of illness, whether the patient is APO, fasting, whether the patient is on TPN or NGT feeding, or the patient is having regular meals. So first, in critically ill or NP or high blood glucose levels, we should start the patient on insulin infusion. So dilute 50 units of regular insulin in 50 ml in syringe with pump. So regular this rapid insulin analogs also can be used here. So when you dilute this, 1 unit will come as 1 ml, 1 unit per 1 ml per hour. So the starting rate, how should we start it? So for example, if the glucose is 346, so divided by 100, so it will be 3.4 units per hour. So then you have to titrate it according. So usually all the teachings will be like if the blood glucose is going from 300 to 400, you increase the insulin dose by twice, 6 to 12 units per hour. It shouldn't be done like that. There are various protocols. This is what I used to follow. So this is the AID insulin infusion protocol. So consider the previous sugar was around 350. We had started at 3.5 units per hour. So then the next hour at 10 a.m. it was 350, and 11 a.m. if it is 400. So the blood glucose has gone high by more than 50. So you have to look into this column, the column of blood glucose more than 200. And in that the blood glucose more than has increased. So what is the instruction? You have to increase the infusion by 2 delta. So then again go to the delta table. Here our current insulin infusion rate is 3.5, right? So what was the instruction? You have to change it to 2 delta. So look into the 2 delta column. So you have to multiply 2 into 2. So the rate is 2 times 2 delta means 2 into 2 rate change. So we have to increase by to 6 units per hour. So like this for each, for example, if the insulin is dropped from 350 to 250, the blood glucose is dropped by more than around 100 mg. So you have to decrease the infusion by delta. And here, so already the infusion rate was 3.5, and you have to reduce the rate by delta. So you have to reduce it by 1 hour, and you can make it as 2.5 units per hour. So like this, you have to slowly titrate hourly based on the GRBS value. So then once the patient is stable, he is able to take oral diet, then you have to change it from infusion to basal bolus regimen. So how do we switch over it? So first we have to calculate the total daily dose of insulin. That is, say around 100 units was given over a period of 24 hours. You have to take around 60 to 80 percentage of it. So better to take 75 percentage. Why this reduction is because on admission, the patient would have been having higher glucotoxicity and the stress factor. So to negate that, we are taking around 60 to 80 percentage of it. And so from if it is 100 units over 24 hours, you take 75 units. Then you split that into 50% for basal insulin and 50% for prandial insulin. So around 38 units of glargine or degludec should be given 2 hours before the first meal, and then you stop insulin infusion. And the prandial insulin, remaining 36 should be divided into 3 doses and given accordingly. So that is for critically ill patients. So for non-critically ill, normal eating pattern, we have to definitely go for basal bolus regimen with correctional doses. So 40% can be taken, so it can be split as 60 and 40, that is 40% basal and 60% bolus. Or maybe 50-50 also can be taken. So this basal bolus regimen is just the sliding scale. So ideally basal bolus regimen is a physiological way of glycemic control, and ADA, all the guidelines recommend implementing basal bolus regimen only. So it addresses 3 components: basal fasting state insulin requirement, bolus is mealtime insulin requirement, and correction is unexpected glucose elevations or dispose of elevated hyperglycemia. So the target range is like fasting or the pre-meal should be less than 180 and the postprandial should be less than 180. So why basal bolus regimen is recommended? It's based on various trials. This is one trial on non-critically ill patients, the RAPID-2 trial. Which concludes that the treatment with insulin glargine and glucosamine resulted in significant improvement in glycemic control compared with that achieved with the use of sliding scale infusion alone. So basal bolus insulin regimen is preferred over sliding scale infusion in the management of non-critically ill hospitalized patients with type 2 diabetes. And there was another trial, RAPID-2 surgery trial, which was predominantly in surgical patients, and that study also concluded that a basal bolus regimen is preferred over sliding scale infusion. So how do you start basal bolus regimen? See, for insulin sensitive patients, that's elderly, cathetic, renal failure, liver failure, patients with poor oral intake, stress hyperglycemia, you can start with 0.3 units per kg per day. So consider if it is like 50 units, you have to take only around 18 units per day, and then you split it into 50-50 or 40 and 60%. If it is usual patients, then you can go for most patients who are expected to eat all or most of their meals, go with the 0.5 units per kg per day. If they are highly insulin resistant, or whether they are receiving glucocorticoids, obesity, diabetics receiving more than 80 units per day of insulin, then you go with the 0.75 to 1 unit per kg per day. So what is this correction bolus? See, now you have set in the patient is there, you have set a basal bolus regimen. You consider like at 2666 and instead of 6 units at 10 p.m. for example. Now we have a baseline dose with us. Now we have to set the correction bolus dose. See, it's not like we have started the basal bolus regimen and all the sugar levels will come down immediately. We have to give correction bolus dose also. So what is that? That is the correction insulin dose is given to correct hyperglycemia in addition to the nutritional bolus dose. So how do we calculate it? It is based on the insulin sensitivity factor. What it is the 1 unit of insulin which will reduce the blood glucose by how many units. So how to calculate this correction insulin dose? So if you are using asparglucin, 1800 divided by total daily dose will give the insulin sensitivity factor. If you are using regular insulin, 1500 divided by total daily dose will give you the factor. So for example, if you are using Sparta. So 1800 divided by 45 will give 40. So that indicates that 1 unit of extra aspart will reduce the insulin level, glucose level by 40 mg. So for example, if the pre-meal glucose is 200 and your baseline aspart dose was 6 unit and the target you are setting as 120, along with 6 units of aspartate, you have to add 2 more units of aspartate so that your post-meal glucose might be on the postprandial level will be on the control. But again, if the postprandial insulin, again, if it is not coming under glucose, even after giving 8 units of aspartate, the postprandial is around 250, give another 2 units based on this ISF and then bring down the postprandial level also. So, next is whether to give sliding scale or not, use it or not use. Actually, sliding scale is an outdated thing. Why? Because it's a non-physiological way with retrospective reaction to blood glucose levels. And there is poor glycemic control and increased risk of hypoglycemia. It promotes glucose roller coaster and cannot predict insulin dosage requirements, not individualized. So, basically, you're adding fuel to the fire. Why? Because consider the sugar is 400, you are giving 8 units. Who set it? We only decide that thing. We are giving 8 units of attractant, and then the sugars will drop to 250, and again there will be rebound hyperglycemia. So this waxing waning, the sugar increase in glucose and hyperglycemia, all these lead to reactive oxygen, increased reactive oxygen species, and it might add fuel to the fire. So it's preferably not advisable to use sliding scale infusion at all. But there are certain times when sliding scale can be tried. But although I'm telling this with a disclaimer. So this is one study where they used a sliding scale only in patients who had very mild hyperglycemia, that is less than 180 mg per deciliter, and they found out that sliding scale infusion alone achieved glycemic control in most non-ICU patients with admission blood glucose less than 180. So use of sliding scale infusion may be a viable option for certain patients with mild hyperglycemia. If the sugars are 200, 250, please don't use sliding scale infusion. You will be giving more harm to the patients. So the next is inpatient use of non-insulin glucose lowering therapies. So the criteria for continuing oral non-insulin injectable hypoglycemic agents include low-risk stable patient, HbA1c less than 8%, eating more than 50% diet, expected discharge within 24 to 48 hours, no plans for contrast studies, no acute renal failure, no steroid therapy, and no infection. Then you can continue this oral agents. So what are the agents? The first is metformin. It's not like cannot be used. It can be used if there's only mild hyperglycemia or to bring down the insulin resistance. Only better to avoid in case of renal insufficiency or when alienated contrast studies are planned. Although ACR guidelines, recent ACR American College of Radiology have told that you can continue metformin even when alienated contrast are being planned, but it's better to avoid for safety purpose. So sulfonylureas and meglitinates, unpredictable hypoglycemia in patients who are eating reliably. So one thing is whenever the patient is on insulin, it's better to avoid sulfonylureas along with it. You cannot predict when the patient will go for hypoglycemia and all. So next is pioglitazone, the fluid retention, especially in combination with the insulin, so better to avoid. And GLP-1 analogs, nausea, and should be withheld in acutely ill patients. SGLT2 inhibitors to avoid because it can lead to dehydration, urosepsis, ketosis, and all. So, and DPP-4 inhibitors may be okay, and there are studies which have shown that treatment with sitagliptin alone or in combination with basal insulin safe and effective management of hyperglycemia in general medicine and surgery patients with type 2 diabetes individuals. So, what to do when the patient is NPO? Already, as I said earlier, you can start the insulin infusion and titrate as per the early insulin infusion protocol. If not possible, then you can administer basal insulin, either NPH or glargine or regular, 50% of the requirement may be started, plus correctional doses of rapid acting analogs may be given as needed. So moving on to enteral feeding. So here we can use a long-acting basal insulin along with correctional short-acting insulin. It's an effective strategy to manage hyperglycemia during enteral nutrition. So enteral feed protocol, basal alone or basal with 3 or 4 short-acting and 2 long-acting. So here you can take a 60% bolus and 40% basal of the total daily dose required. And very important thing is bolus should be followed compulsorily by a feed in 30 minutes. So individual modification may be needed based on the quantity, quality, or frequency of the feeds. So an example is here a 50-year-old gentleman whose weight is 85 kg on entered feeds, GRP is 420. So how to manage this? So daily basal insulin requirement I have taken as 0.4 units. So 85 to 0.4 around 34 units. So of the 34 units, 60% bolus means 20 units to be given before feeds. So you can give us 5 units of regular insulin 6th hourly or 7 units at 8th hourly plus correction bolus as needed, and 40% basal, so 14 units as single basal dose of glargine can be given now. Next, moving on to TPN induced hyperglycemia. Here definitely insulin is required and can be most of the time IV or subcutaneous, along with adding it directly to the TPN bag will be required. So advantage steady state delivery used in malnourished with no subcutaneous bag prevents the need of frequent injections. Disadvantage is risk of hypoglycemia and paucity of studies. So how to calculate the insulin dose in such patients? So if it's a known diabetes or and blood glucose more than 200 mg, you have to administer 1 unit of regular insulin per 5 grams of TPN glucose. So most of the TPN bags will have around 10 grams of dextrose. And next, if the non-diabetes patient or steroid treatment and blood glucose less than 200, you can use 1 unit per 10 gram of glucose levels. And if the hyperglycemia associated with parental nutrition but no pre-existing diabetes, 1 unit per 20 gram of parental nutrition glucose. So okay, now you have administered regular insulin in the TPN bag. So what next? If the glucose levels remains high, mostly we might require this because it won't be getting controlled with only if you are adding that regular insulin in the TPN bag. You start the patient on insulin infusion protocol. So then once stable IV rate is reached, then you calculate about 24 hours what was the total dose is there. So then you add next day of that 75 to 80% of estimated total daily dose, you add for example 50 units was required over a period of 24 hours. You can take around the 40 units and administer in the TPN bag the next day. So if the patient has diabetes for many years, what you can do is 40% of the requirement as a single basal insulin and the rest of the 60% as regular insulin can be added to the TPN bag. So moving on to steroid-induced hyperglycemia. So basic thing is like here the trick is you have to administer insulin. You have to neutralize the effect of glucocorticoid by administering insulin, which will exactly mimic the effect of mimic the pharmacokinetics of glucocorticoids. So like see for example, if you are administering prednisolone as a OD dose. The glucose, you can see the glucose, see the glucose profile. The glucose values mostly will start rise from pre-lunch and post-lunch and then slowly move towards the normal range in the pre-dinner state. So which insulin is preferred thing? So the NPH will mostly mimic the hyperglycemic effect of prednisolone. So for hydrocortisone, you should administer regular insulin to counter the hyperglycemia effect. For prednisolone or methylprednisolone, NPH should be administered. For dexamethasone, either glargine diluted with correction regular insulin or twice daily NPH with regular or rapid acting insulin can be administered. See, for example, okay. So the dose-dependent hyperglycemia, how to calculate the doses? If the patient is on a Viceron 10 mg, so 0.1 unit of NPH of 0.1 unit per kg of NPH should be for 60 kgs. You have to give 6 units of NPH in the morning time, along with or 1 hour prior to administering Viceron. And similarly, for hydrocortisone, it's 50 mg. You have to administer. You have to add 6 units of actrapid along with the already existing baseline actrapid. So moving on to high renal failure patients. What happens is in hemodialysis, here in this patient, the hemodialysis was planned after lunch. So what happens is during dialysis there is removal of insulin by absorption, and also there is blood glucose decreased by means of diffusion. So post dialysis there will be compensatory increase in hyperglycemia due to increased release of counter-regulatory hormones. And the day-to-day variation of insulin requirements are like this is routine IST patients. Before dialysis, you can see that during night time, that is around 12 a.m. to 6 a.m., the insulin requirements will be on the lower side. This is what it is. So after dialysis, even that insulin requirement goes down. This is because after dialysis, the insulin sensitivity goes high, and the requirement comes down. So what we have to do is we have to reduce the basic insulin rate by 25% post hemodialysis compared with pre-hemodialysis, while bolus did not change significantly. So on dialysis days, basal insulin dose same, and if the bolus insulin dose, you have to reduce the mealtime insulin for meal nearest to the dialysis time. That is, if the patient is planned for dialysis post lunch, you have to reduce the meal lunch time bolus insulin. On the post dialysis days, you reduce the basal insulin by 25% and then continue the same bolus insulin. So pre-fitness, patient is fit for surgery if the HbA1c level is less than 8%, and the blood glucose concentration is 100 to 180. If the pre-op HbA1c is less than 8%, less than 8% is not possible, then you bring it down to 100 to 180 and then do fitness. So the final slide, at discharge, HbA1c less than 7, restart outpatient treatment regimen. If it is 7 to 9%, restart OP non-insulin anti-diabetic agents and add once daily basal insulin at 50% of hospital dose. If it is HbA1c more than 9%, start basal bolus at same hospital dose, or restart outpatient non-insulin anti-diabetic agent and add on once daily basal insulin at 80% of hospital dose. So please remember, OADs are not suitable if patients having 5S6, septic, surgery, starving, serious organ damage. Once GRBS value is not enough, send lab RBS and HbA1c. Key points: hyperglycemia is an important issue in patients. Treat if more than 180 and maintain between 140 to 180. Basal bolus or insulin infusion is a preferred thing. Sliding state should be discouraged. Frequent and regular monitoring is needed. Thank you.
Yes, thank you, Dr. Dev Franklin. It's a very big topic. I think time is not there for you to fully cover. Anyway, you have rushed through this topic, very difficult topic indeed. Nice. You have done justice to the topic. Yes. Only one thing, time is out because floor day you can ask the questions during the snack time. I would say only one thing. Don't go for reactive insulin titration. Go for proactive insulin titration. Proactive means yesterday, suppose you are going to deal with today's morning dose of insulin. See the yesterday fasting and the pre-lunch. Judge the today's, what would be the blood sugar today pre-lunch. You have to judge, anticipate, and then do. That is called proactive. It is all based on the rigorous learning curve of the individual, no matter how much algorithms are put. Okay. With these few words, I would sum up this entire session.
Thank you. Definitely, it's a difficult topic, but excellent presentation. Thank you, sir. I would like both the chairpersons to felicitate our speaker